years in focusing on rehabilitative efforts for our offenders while they're incarcerated, so when they come out, that they will be much more productive citizens and live a healthier lifestyle as well. I am the Drug and Alcohol Program Manager for the department. My bureau is the Bureau of Treatment Services, and I am in the Substance-Related and Addictive Disorders section. I'm going to give you a little bit of a history. We have 26 state correctional facilities and a motivational boot camp. We have 2 female prisons, Muncie and Cambridge Springs. We have 14 community correctional facilities and 40 contract facilities. We have about 16,000 employees in Pennsylvania, more than 51,000 offenders. Unlike some other systems, we do not have any supervision with the county jails or the probation board. So we do not have any jurisdiction over them. They are separate entities and departments. For our offenders to enter in treatment, we use the risk screening tool. Years ago, we used to use the LSIR, but as some may know, the cost with that is pretty extensive for our offenders. So the department has developed the risk screening tool, which is an evidence-based tool. And so what we have determined based on risk need responsivity principles, that we do not provide treatment to lower risk offenders. So if an offender comes in, he takes the RST tool, the assessment, he does not receive treatment in the state correctional facility. However, we don't deny that he does need some type of treatment. We just don't want to contaminate him with medium to high risk offenders. So what we do with those offenders that are low risk is we make the recommendation for them to move in to community-based treatment upon their release. The treatment qualifications within our bureau is that we have standardized in the past 10 years all of our treatment modalities. So every treatment that any offender would participate in has all been standardized, which has, with 26 facilities and 16,000 staff, is definitely a necessity, but we still utilize individualized components, and I'm going to show you how we do that. However, most of our treatment programs are based on the principles of effective intervention, offender intervention. So we have to, again, not only are we getting offenders that need treatment, but we also have the criminogenic needs as well. So we have criminogenic needs, we have the substance use disorder on top of those types of areas to identify. We do individualized treatment through individualized treatment plans where we identify measurable goals to work on with the offenders throughout the course of their treatment. For the substance use disorder, we've worked with Kevin Knight, the author of the Texas Christian University Drug Screen 2, in identifying the level of care for our patients in the facility. So if an offender scores out as a TCU score 0 to 2, we do not require them to participate in treatment. A TCU score of 3 to 5, which identifies dependence, we have placed in outpatient treatment. And a TCU score of 6 to 9, we place in therapeutic community, residential treatment. We have recently worked with Kevin Knight to pilot the TCU 5, which aligns with the DSM 5. So hopefully within the next year or so, we'll see the progression utilizing the TCU 5, which we're very excited about. We are also in the process of identifying and working with a pilot with the Department of Drug and Alcohol Programming for Pennsylvania, where an offender is given the PCPC, which is similar to the ASAM, but Pennsylvania Client Placement Criteria. It's the 3rd edition that was recently released. It is given to the offender prior to their release, so we can determine then the next level of care for them as they're going out into the community. Again, continuity of care being the most important for our offenders. Currently, our statistics look as follow. As a department, we can provide therapeutic community treatment annually for 7,340 offenders. We also provide outpatient treatment for 5,760 offenders. About 70% of our population needs some type of substance use disorder treatment. So there are significant needs within the department. We have approximately 200 drug and alcohol treatment specialists and drug and alcohol treatment specialist supervisors in the department. I have 8 facilities that are actually contracted out for outpatient, and then we have 2 facilities that do therapeutic community. Beyond that, all facilities provide these treatment services. So we have 43 therapeutic community treatment programs in our department. This is what I have oversight of, as well as the other drug and alcohol treatment programs. We average about 288 outpatient sessions a week total in the department. Our primary ages of our offenders in substance abuse treatment are 16 to 27 years of age and 28 to 35 years of age. Most offenders in substance abuse treatment have an 8th to 12th grade academic level, and 41 to 55% of our offenders in substance abuse treatment are assessed at medium risk. When I came into this position a little over 2 years ago, I've been with the department 10 plus years. And we had significant concerns with wanting to make sure that our programming was aligning with evidence-based practices, that our offenders were getting the best quality treatment because we have them there. It's not like they're going out in the community where some of the structures that you have difficulty with having them maintain treatment. We encounter some of that, but not as much resistance. They're pretty much there. So we really want to capitalize on the fact that they're in our facilities, they have needs, and we want to be able to provide them services. So what we do, and this is a little bit different, I don't know how your communities work, but we have 49 audit standards that I annually go out to every single facility with an audit team, and we audit each of our facilities. The audit areas include file and documentation, substance use treatment and policy enforcement, the TC program specifically, training and clinical supervision. If they are in non-compliance with a standard or an aspect of our audit, they have to have a follow-up in 6 months. So we actually utilize the ARM system for our auditing in the state. So at any time I can pull up, see where they're compliant, where they're non-compliant, and what they're doing as a work plan to make changes to those non-compliance. And then we follow up in 6 months. And those are done annually. The Bureau of Treatment Services, as I said, is the division I work for. I oversee the substance-related and addictive disorders section for addiction treatment. We also have a standardized treatment. For time's sake, I'm not going to go into everything we do with standardized treatment. However, I do have it in the PowerPoint, so when they offer that to you online, you will be able to go through and see specifically what we do for standardized treatment. We do assessments as soon as offenders come into the facility. Within the first 2 weeks, they are given a whole line of assessments, and that's done at one facility for the men and one facility for the females. So we have it streamlined pretty easily. The standardized treatment that we do provide is violence prevention. We provide thinking for a change, domestic violence programming, long-term offenders, and inside-out dads. That's our standardized treatment that's not addiction treatment. The addictive services that we provide, treatment services, are outpatient, co-occurring therapeutic community, Hispanic therapeutic community, general population as we identify it, therapeutic community. We have a state intermediate punishment program. We have self-help programming, peer assistant programming, and recovery programs. This is all about standardized treatment, and it gives you specifically of what we're doing. I'm going to bypass that quickly, and I'm not going to really touch on this a lot, but I want you to see the length of time and the actual way we are able to implement treatment within our correctional institutions. We have an outpatient program. This is provided to all general population that is medium to high risk on the RST and assess out of the score of 3 to 5. We provide 41 sessions. That includes MET programming, CBT addiction concepts, relapse prevention, commitment to change, and some introduction to self-help. We are currently in the middle of revising that entire curricula based on evidence-based practices, and we're utilizing a new direction program from Hazelden that was developed by the Minnesota Department of Corrections. So it's a wonderful program. We operate on outpatient 3 times a week, an hour-and-a-half group. We have co-occurring outpatient treatment at all facilities, 24 of our facilities, missing 2 there. These offenders have mental health diagnoses, which we identify with the DOJ as scores of C and D based on diagnosis. These are moderate to high-risk offenders. They have TCU scores of 3 to 5, and we actually have a 47-session program that we integrate treatment with psychology staff and drug and alcohol treatment staff. So it's wonderful that our ITPs are actually done by psychology and our drug and alcohol treatment staff. We facilitate this 3 times a week, and they are 1-hour group sessions. Anytime we make any changes to our programming, which this was just a recent change, we do a review at 6 months and then every year annually for all of our programming. We know how quickly treatment changes, evidence practices, different things like that, so we like to stay up to date on that. We also like to know what's working for our offenders, what's working for staff, what's not working as well. So our review will be conducted in September for this, 6 months after its first implementation. We then have therapeutic communities at all of our facilities. All 26 facilities have therapeutic communities. They are for general population, moderate to high risk, TCU score of 6 to 9, and this treatment is done for 4 months. We have 3 phases, similar to, it's actually the TC model program, and we are working currently on revising both of these to align with correctional-based models for TC programming and for co-occurring disorders as well. So Hispanic Therapeutic Community is a program that we provide at SCI Chester. It's for Hispanic offenders that are bilingual or Spanish-speaking only. It's for moderate to high risk and a TCU score of 6 to 9. Our co-occurring disorder therapeutic communities are at SCI Muncie, which is our female facility, and Retreat. They are scores, mental health scores of C or D. Offenders, moderate to high risk, TCU scores of 6 to 9. They are in 6 months of treatment with co-occurring disorders. And we're also in the final stages of revising that with some lead experts in the field with co-occurring disorder therapeutic community model and curricula. We have a state intermediate punishment program. I don't know if many of you are familiar with this, but it's for lower risk offenders who have addiction needs. The sentence is a flat sentencing of 24 months. I'm sorry, this is a little small. I wasn't planning on a smaller screen. And we have 4 levels. So for 7 months, they are in an SCI participating in substance use disorder therapeutic community. Level 2 is where they're there for 2 months in the community-based inpatient setting. Level 3 is 6 months community-based outpatient treatment. And then level 4 is the rest of their duration in a supervised reintegration through the community. CECs, it could be their own home placement, and so forth. We also have every facility at least 1 time a day has to offer self-help programming. So we have Alcoholics Anonymous, Narcotics Anonymous, Al-Anon, Smart Recovery, Double Trouble in Recovery, and Gamblers Anonymous is just starting to come onto the boat in our state in corrections. Why we had to choose self-management and recovery training? We have a lot of staff that have been in our department for many years. They are much into 12-step facilitation. I am not biased in any way. However, we have had several court rulings that if we make them, require them to attend 12-step meetings, that's a violation of First Amendment rights. So SMART originated in 1994. It's a secular-based program for addictive substances and behaviors. So this is what we utilize for gambling as well, an alternative from the 12-step. It does not require the label of an alcoholic or addict, and it uses a 4-point program enhancing and maintaining motivation, coping with urges, problem solving, and lifestyle balance. We also have a substance use disorder peer assistant training program. We have actually had other state correctional facilities contact us regarding our program for peer assistance. It was launched in 2014. It's a training that we have our DATs do with the peer assistants at each facility. It's 2 days and 4 hours in length, so 8 hours total. The supervision forms, we actually have peer assistants. The participants in the group will actually complete supervision forms, peer reviews on the peer assistants for a duration of every month as they come into being a peer assistant, and then 6 months after that, it is done quarterly. These are some of the things that we identify in our training with them. We actually have official job descriptions. They have to interview for the position. It's just as something they would be able to do. We also have certified peer support specialists in our facilities, in every single one of our correctional facilities. So they are actually certified as peer supports and can actually go into the community and get treatment, or get jobs doing those in that regard. Why did we pick a recovery program? So I'm here to tell you, I want to give you a little bit of history of what we do. Most people don't really know. Corrections is like the secret in a lot of ways of what goes on. And there's very few chatter outside in the community. We have done a lot of extensive work to try to increase our access to community-based providers in other departments outside of corrections to make sure that continuity of care is continued and that we have good rapport and relationships. So we chose a recovery program because after I changed the audit process, we actually then did one-on-one interviews with offenders and staff, where offenders were expressing interest in staying on our therapeutic communities or in treatment, outpatient, after they've met all of their requirements. So once we were like, what can we provide for them to provide this environment that they're interested in if they're motivated for recovery? So we have, and if offender completes TC treatment, right now they go back into a general population unit. Also, outpatient is done in an education building, which is, if you look at a state correctional facility in Pennsylvania, we are a hub. So in the middle of the correctional facility would be the education building, and then it's a spoke wheel out to the housing units. The outpatient services are done in that education building. They then leave that treatment group after an hour and a half and go back to general population. We know general population isn't the most ideal for someone who is really invested in their recovery. The Office of National Drug Control Policy, their research indicates that if TC is initiated prior to 12 to 18 months from their anticipated release, and they go back into general population after they've completed TC, the 3 months or more that they remain there, treatment becomes less effective for them. So we really do not want to waste our resources or their time in this. We do try to get offenders into treatment 12 to 18 months prior to their release. We base this extensively because there is not currently a recovery model in correctional settings in the U.S. So we developed this based on SAMHSA's, as Dr. Brown had indicated, the working definition of what is recovery. And recovery is a process of change whereby individuals work to improve their own health and wellness and to live with a meaningful life in a community of their choice while striving to achieve their full potential. And this is very important to us. So we based our programming off of the principles of recovery by SAMHSA. So we have, again, peer assistance and CPSs. We work very hard to build relationships. We have LGBTIQ represented, culturally based. We have gender responsive programming for females and males and Spanish-speaking individuals as well. We have addressing a trauma. We do seeking safety in all of our state correctional facilities for offenders who assess out at needing trauma. And we were just recently trained from the Gain Center as a trauma trainer for the U.S. We include individual, family, and community strengths and responsibilities, and we discuss the definition on respect, which is very important and sometimes very distorted with our criminal population. Offenders who are eligible for our recovery model programming are able to participate in after they've completed a substance use treatment program. So they've had to complete TC or outpatient treatment in the facility. They reside on a housing unit together as a recovery unit, and they are assigned a DATS, a drug and alcohol treatment specialist, who is assigned to the recovery unit and does 10 to 12 sessions a week with them. There are also 2 to 3 substance use disorder peer assistants that facilitate 8 sessions a week. Offenders meet individually with the DATS to review their correctional plan evaluation once they enter in, and they develop a recovery plan in which staff work with offenders to set measurable goals. Offenders will choose what sessions they want to participate in and will work with DATS recommendations. They receive a certificate not for what they've participated in, but for the amount of days they've spent on the recovery unit, which is another motivator as well. They are then assessed with the PCPC prior to their release, so we can set up their continuum of care once they leave our facilities. And this is just the model that we have set up where they've completed treatment. They have to volunteer for the program. It's not mandatory nor parole mandated. And then we have participation in treatment, PCPC. We also, with our research, are going to be utilizing some scales for measurement purposes. The recovery unit workshops are open-ended. They can be entered at any time. There are 20 modules that are gender neutral and 1 module specific to female offenders. The program has 188 sessions, and as evidence-based curricula is identified, we continually add to this menu. There are additional workshops, such as 9 self-help groups a week, addictions journaling, natural meditation, and addictions book club. These are the workshops that are included on our recovery model. And if I can show you, I'm not real computer savvy, but this is our actual matrix for their programs, and it's in a full screen, so it's hard to see all of it. But it gives you, in the highlights of blue and green, are what Offenders are allowed to facilitate and not, but I have this if you are interested in seeing it. Quickly, because I know I'm running out of time. Oh, how do I get my PowerPoint back up? Okay. Living in Balance is a program that we utilize. Beat the Streets. SHIELD for our HIV. Hepatitis C programming from the CDC and Veterans Affairs. I recently have written a program called Addictions Journaling. The purpose of this was it was goal-directed for clients to aim to reduce substance use and substance-related behavior as a process of self-reflection. So there's a lot of art exercises and journaling for them based on, there's several questions and things from their childhood. It has trauma layering components, and it's currently under publication review. The journal is intended to help participants think and write about their substance use problem. What I really wanted with the goal was our offenders would say to me, Ms. Snyder, you want us to go into treatment when we get this to the streets. You want us to go into inpatient, outpatient. You want us to get a job. You want me to go back into all of these things that I did before. And I don't really have the time to attend all these self-help meetings, the 90-90-90, different things like that. So what I really wanted them to be able to do was to help in their recovery by using themselves and not have to use external sources if they did not have time to do that. We also utilize an addictions book club. So we have identified a listing of books that we provide to each of our facilities. And they meet once a week, and the offenders get to read and talk about the different books. 5 Survivors, Codependent No More. We brought Melody Beatty in last year, who actually got to speak to our staff about her books and about working in the field that she does. It was a fabulous presentation. We use SAMHSA's Intensive Outpatient Matrix program. We just use pieces of it. We don't use it in its entirety. We like their processing groups that they have, that if offenders are interested in talking about different topics. We utilize Living Skills by Hazelden, which is a brand new program that they've just redid, which is absolutely fabulous for our population in guidance of hygiene and self-care, sexual health, looking for work, personal growth, setting and attaining goals, parenting. We also have the Inside Out Smart Recovery Program. This is CBT based, again, and it's outside of SMART, but similar in many ways. It's to prevent offender recidivism through carefully designed scientific-based secular programming. It's been utilized in drug courts, correctional institutions, DUI diversion programs. It's a great program. We also had the honor of having Ted Phelps, the author of Natural Meditation, who came out and facilitated, had our staff learn how to be facilitators for natural meditation. Why we did not utilize mindfulness or other meditation programs or meditative styles was because we really need something that is beneficial to all of our offenders. So we need something that is not spiritual based, nor is it cultural based. We need it to be a flat playing field for that. And this is the only program that currently exists like that, is the Natural Meditation Program. And then again, we have the AA, NA, Double Trouble in Recovery. Our theory, I was not able to implement our recovery unit model into the correctional facilities. As we know, in the U.S. and in Pennsylvania, we're under a current heroin epidemic that by our governor has become priority for us. So unfortunately, the theory that I had with this going into this recovery model would decrease relapse, reduce recidivism, misconduct behaviors on a facility, increase use of community-based treatment services, increase motivation of change, decrease cravings, improve general attitudes and beliefs, and decrease criminal sentiments. But we are now getting underway with that research project because unfortunately it was held back because we are working on a Vivitrol expansion. And I'm going to close up very quickly, but we as a department have taken the initiative. 2 years ago, we started a Vivitrol project with a Second Chance Act grant with the offenders at SCI Muncie. That program, we did not actually research the evidence of the progress with the offenders. We only researched the process. So we have a process evaluation that determined how we did it, what we were doing, if we were doing it accurately. So as of July 6th, we now have expanded Vivitrol beyond women. We now utilize it at SCI Muncie, Pittsburgh, Chester, Mahanoy, and Graterford. The counties that the offenders have to be released to are Lehigh, Philadelphia, Allegheny, and Dauphin, and they must meet the protocol type criteria, which I'll cover with you. There are 175 offenders that are going to be part of this project, It's currently being researched by the University of Pennsylvania, and we have implemented social workers at every one of our facilities to assist in this process. I don't have time to show you the video, but I do have a great video that we show our offenders that's very simple and basic on what Vivitrol is. For offenders to be able to participate, they have to also go into some type of substance use treatment as well. So they have to complete what we have and then plan to go into community-based treatment. 1 week prior to the release, they're provided the injection by our medical staff. They are medium to high-risk offenders. No liver failure, no acute hepatitis. They must be opiate and alcohol-free. And they must be within 2 months to 18 months of their minimum dates. And they begin this process working with the social worker 6 weeks prior to release. And this is our protocol. And again, as other correctional facilities are coming on board across the United States, they are utilizing our protocol that we have in place. So it has been wonderful to be the lead on utilizing and coming up with a great protocol. And one thing that I just want to stress to you before I close is the importance that we have been working on. The department has worked with the University of Pittsburgh, the School of Pharmacy. We have a criminal justice work group. Because of our heroin epidemic and other drugs as well, we have worked with them, and they created what we have, the overdosefreepa.org website. This was created for anyone who lives in Pennsylvania as a hub to steer them into direction with treatment, overdose data, any news coming out regarding drugs and alcohol use. It has educational components for both healthcare professionals, criminal justice, friends, family, community. It's a great hub resource for anyone. We also utilize local resources and emergency information in there as well. It's a wonderful tool, and I would recommend, if you have the opportunity to create one of these in your state, in your area, it is very, very important for the community. In 2016, hopefully we'll come back and I'll get to see most of you. We will have our Vivitrol study results, which will be wonderful, hopefully. We'll have our recovery model results as well. We will have our new co-occurring therapeutic community model and curricula, which I would be very excited to share with everyone. Our improvements to outpatient treatment. We have a significant training going underway for our substance use disorder staff for clinical supervision and performance-based alignments. And again, performance-based measures for treatment, which are very significant inside and outside of prison. This is my contact information, and I'm sorry I went a few minutes over. Thank you all very much. I know that I did not come with significant research data and that we were providing more of a theory, but we are very thankful to be able to provide and develop the model for correctional settings for recovery programs. Thank you. A lot of information.
Yeah. I had a quick, I feel like I had so many questions while you were talking, and just a few, they disappeared. Maybe I drank too much last night. So addiction.
I don't know, what did doctors say about brain cells?
Addiction conference joke.
Yeah.
I love seeing that you guys utilize SMART. That's awesome. Congratulations on that. And secondly, for the overdose prevention, do you guys do anything with naloxone?
We have actually, just as a state, gotten on board with that. Yes.